Deputy Vice Chancellor, Research, Innovation and Strategic Partnerships, Registrar, University Librarian, Provost of the College of Medicine, Provost of the Postgraduate College, the Dean, Faculty of Clinical Sciences, Deans of other faculties and of students, Directors of institutes, Heads of departments, former Vice Chancellors of this university, distinguished guests, ladies and gentlemen. The 548th University of Ibadan Inaugural Lecture will be delivered this evening by Professor Jesse Abiodun Olubanjo Otegbayo of the Department of Medicine on behalf of the Faculty of Clinical Sciences in the College of Medicine. Professor Jesse Abiodun Olubanjo Otegbayo was born on 17 December 1961 in Sekondi, Ghana, to the family of late Pastor Israel Akombi and Deaconess Florence Aduke Otegbayo. He was at different times attended St. Peter's Primary School, Sekondi, Ghana, Inigbo, Methodist Primary School, Otoile, and Baptist Primary School, Ilaorongun. He started his secondary education at Ila Grammar School, Ilaorongun, then Methodist Grammar School, Otoile. He later completed his secondary education at the Command Secondary School, Kaduna, in 1983. He gained admission to study medicine and surgery at the University of Ibadan in the same year and graduated with MBBS degree in 1989. Professor Otegbayo did the one-year internship program at the Obafemi Awolowo University Teaching Hospitals Complex, Ile-Ife, in January 1990. He then proceeded to the Nigerian Navy Medical Center, Uhiapele, Saple, in the then Bendel State, for the Mandatory National Youth Service Program, NYSC. He did his medical residency training program at the University College Hospital, Ibadan, in 1992 in internal medicine, sub-specializing in gastroenterology and hepatology, and obtained the fellowship of the West African College of Physicians in 1998. Professor Jesse Otegbayo was appointed lecturer grade 1 and consultant physician and gastroenterologist in the Department of Medicine, University of Ibadan, and also in the University College Hospital, Ibadan in 1998. He was promoted senior lecturer in 2002, reader in 2005, and professor in 2008. In 2002, he obtained a postgraduate certificate in gastroenterology at the University of Tel Aviv, Israel, and Chaim Sheba Medical Center, Tel Hashoma, also in Israel. Professor Otegbayo completed a master's degree in chemical pathology and immunology at the University of Ibadan. In 2003, he subsequently obtained a PhD in immunology at the University of Ibadan in 2011. Professor Otegbayo has served this university in various capacities. He was subbed in undergraduate College of Medicine, University of Ibadan, member Court of Governors, University of Ibadan, member Board of Health, University Health Service, member of the board of the University College Hospital, UCH, and head, Department of Medicine, University of Ibadan. Professor Otegbayo has received several grants, awards, and fellowships, some of which are the University of Ibadan Senate Research Grant in 1999 to study the prevalence of Helicobacter pylori in gastroduodenal diseases, and also pharmaceuticals to study the safety and efficacy of omeprazole in dyspeptic patients. Outside this university, he has served as examiner for universities and hospitals in Nigeria, Cameroon, and Ghana for MBBS, primary, membership, and fellowship of the West African College of Physicians. He has also been involved in assessment of candidates for professorship in many Nigerian universities. Professor Otegbayo is presently a second-term Chief Medical Director of the University College Hospital, Ibadan. In 2023, he obtained the Doctor of Medicine degree, MD, of the National Postgraduate College of Medicine, and also a fellowship of the Nigerian Academy of Medicine. He has several administrative positions, some of which are the Chief Resident, Department of Medicine, President, Association of Resident Doctors, Vice President, National Association of Resident Doctors, Assistant Secretary General, Secretary, Vice Chairman, and Chairman, Medical and Dental Consultants Association of Nigeria, MDCAN, at various times, among others. He has also served as the Director of Clinical Services, Research and Training, as well as the Chairman of the Medical Advisory Committee of the University College Hospital, UCH. Professor J.C. Otegbayo has taught and supervised both undergraduate and postgraduate students to the fellowship levels at the University College Hospital, Ibadan, and Ladoke Akintola University, Osogbo, among several others. His clinical and research interests cover microbial pathobiology in liver and gastrointestinal systems, particularly viral hepatitis, liver cirrhosis, hepatocellular carcinoma, and Helicobacter pylori. Professor Otegbayo has over 100 scholarly papers in both national and international peer-reviewed journals. He is married to Bolanle Omolara Otegbayo, a professor of food science and technology, and presently the provost of the postgraduate school, Bowen University, and they are blessed with lovely children. I now invite Professor Otegbayo to present his inaugural lecture, which is titled The Human Workhorse and Microbial Afflictions, Hepatitis B, its fatal sting and tragic trajectory. Professor Otegbayo.
Vice Chancellor, Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academic, Deputy Vice Chancellor Research, Innovation and Strategic Partnerships, Registrar, University Librarian, Provost of the College of Medicine and of the Postgraduate College, Deans of other faculties and of students, Directors of institutes and centers, distinguished ladies and gentlemen. I'm highly honored to deliver the 548th inaugural lecture on behalf of my faculty of Clinical Sciences. And I thank the faculty for ceding the hosting right to my Department of Medicine. I wish to appreciate the Dean of my faculty, Professor Temidayo Ogundiran, ably represented by Professor Rimadegun today, and for nominating me to deliver this lecture. I also thank our Vice Chancellor, Professor Kayode Adebowale, MNI FAS, for approving my nomination. The Department of Medicine was one of the 10 foundation departments of the University College, Ibadan, in 1948. While this inaugural lecture is the 8th to be delivered by the department till date, it is the second in my subspecialty of gastroenterology and hepatology, the first and the last being in 1973. By God's grace and the will of the authorities of the University of Ibadan, I stand as the first professor of gastroenterology and hepatology since the inception of our great institution. Gastroenterology and hepatology as a subspecialty deals with the study and care of patients with diseases of the digestive system. The etiologies of the diseases that affect the digestive system range from infections such as viruses, bacteria, parasites, fungi, to alcohol, drugs, immunological, degenerative cancers, and congenital disorders. Mr. Vice Chancellor, sir, my interest over the years has focused on microbial pathobiology in the liver and gastrointestinal system. More specifically, I concentrated on viral hepatitis, liver cirrhosis, liver cancer, and Helicobacter pylori infection. This I can profess as my area of expertise, although some mischief makers have defined an expert as someone who leads you astray confidently. But be rest assured that you will not be led astray this evening. My ambition as an undergraduate student while in this university was to become a cardiologist, especially that deals with the study of the diseases of the heart and the blood vessels. During my undergraduate clinical years, I was in the echocardiography suite to observe the procedure. Yours truly saw just a non-specific cloudy movement on the screen. I asked a classmate of mine whether he could see all the features being mentioned, and alas, I had a company. I wanted to join them in the subspecialty to brag about seeing what others were not seeing. When I was ready for subspecialization training, however, there was no vacancy for me in cardiology. The chief resident, who was in charge of placing residents in units, insisted that one of the two of us who are post-part 1 candidates should join the gastrointestinal unit, which we both refused. I later accepted. Though it will appear that my acceptance was fortuitous, it was indeed a divine guidance. By the time I completed residency, there was no vacancy for a consultant post in cardiology, but there was in GIT, and the rest is history. Professor Theodore Francis delivered the first inaugural lecture at gastroenterology unit on Friday, 9th of December 1973. He titled it, "Life Depends on the Liver," to underscore the importance of the liver in the annals of biological survival of man. For the next minute, I will attempt to introduce to you all the liver and its diseases. The liver is an essential organ in the body, and without it, there cannot indeed be life. As the first major metabolic site for ingested foods and other substances after intestinal absorption, it is exposed to various antigens from food, microbes, and microbial degradation products, endotoxins, xenobiotics, drugs, which at times are injurious to the liver itself. The liver has also been associated with divination through the practice of hepatomancy or hepatoscopy in ancient Greece. This is also corroborated in the Bible in Ezekiel chapter 21, verse 21, in the New King James Version, which says, "For the king of Babylon stand at the parting of the road, at the fork of the two roads, to use divination. He shakes the arrows, he consults the images, he looks at the liver." The liver at various times has also been regarded as the seat of life, human feelings and emotion, love and courage, as the saying, "Lily liver," to demonstrate cowardice. The liver is appropriately described as the bodywork or powerhouse of the body, because it is known scientifically to play crucial roles in body metabolism and energy generation. It is known to perform over 500 functions. The huge blood flow into the liver and direct constant contact with microbes and other chemicals is shown on the slide. Although my lecture will focus on microbial risk factors for liver disease, Helicobacter pylori and its catastrophic consequences on the stomach will also be mentioned. Among the major etiologic factors of liver disease, the hepatitis viruses are responsible for about 90%. These viruses form the alphabet soup according to the time of discovery. We therefore have hepatitis A, B, C, D, and E viruses, and they are collectively known as hepatotropic viruses. Other viruses that affect the liver are called non-hepatotropic viruses. The difference between these two groups is just in the severity of the disease they cause, the latter being more severe. Mr. Vice Chancellor, sir, I will take a few minutes to discuss the viral hepatitis while focusing on hepatitis B. Hepatotropic viruses enjoy a tropism in the liver due to the presence of some epitopes on the hepatocyte that readily bind some receptors on the virus, which permits the virus to enter into the liver cell and ultimately lead to a fatal sting and then the tragedy that follows. Hepatitis B virus has a complex biology consisting of a partially double-stranded DNA and a number of antigenic determinants and antibodies that have been found to be useful in the diagnosis of an individual that has either been previously exposed or has been immunized. The slide shows the structure of hepatitis B virus, illustrating key antigens. Professor Baruch Bloomberg serendipitously discovered hepatitis B virus in 1967, which he named Australian antigen, while testing for sera of some Australian aborigines for some differences in protein polymorphism. The virus was eventually named hepatitis B virus. He and his colleagues later developed the vaccine against this virus in 1969. The burden of hepatitis B virus is huge and is the most studied of the hepatotropic viruses. The World Health Organization estimates that about 2 billion people have markers of infection worldwide, and it accounts for about 900,000 deaths each year. There are over 250 million chronic carriers of this virus, and the highest prevalence is found in sub-Saharan Africa and Southeast Asia. In Nigeria, prevalence of hepatitis B virus ranges from 6% to 25%, and more than 20 million people are living with hepatitis B, C, or both. Ajuwon et al. In 2021 estimated that more than 80% of the people with the virus are not aware of their status. In 2008, Otegbayo et al. Reported a co-infection of hepatitis B virus in 12% of patients with HIV infection, and thus compounding the problem of treatment of both viruses. The most effective means of transmission is blood and blood products. Other channels are sexual contact, saliva, organ transplantation. Interestingly, hepatitis virus is about 100 times as infectious as the dreaded HIV infection, and could survive for as long as 6 weeks on a dry surface. It can also resist the temperature of boiling water even after 1 hour and still retains its infectivity. There are individuals who are at a higher risk of acquiring hepatitis B virus infection. These are health workers, contacts of infected persons, men who have sex with men, and those with sexually transmitted diseases. Oladoto and Otegbayo in 2009 reported that hepatitis B virus infection also contributes adversely to fetal outcomes, with higher risk of preterm deliveries, intrauterine fetal deaths, and neonatal deaths. Viral hepatitis can present acutely when the infection is less than 6 months, or chronic when it has lasted more than 6 months, and they may become carriers. Carriers are patients who are positive for this virus but have no symptoms or the disease they can cause. Many cases of acute hepatitis are missed even by medical practitioners because the symptoms are usually non-specific until there is jaundice. The few that develop complications may develop liver failure, hepatic encephalopathy, kidney failure, coagulopathy, and death usually occurs at the fulminant stage. Major contributors to fatality from our study at the University College Hospital Ibadan includes liver failure, gastrointestinal bleeding, and sepsis. Otegbayo 2001. In our study, over 80% of our patients with acute icteric hepatitis were positive for hepatitis B virus, Ola et al. In 2002. Presentation in chronic viral hepatitis is also non-specific. Laboratory investigations, particularly biochemical liver function tests and liver biopsy, are usually required to make a diagnosis. Untreated, it may progress to liver cirrhosis and then to liver cancer. Liver cirrhosis is an advanced stage of chronic liver disease. Signs include leg and abdominal swellings, puffiness of the hair, weight loss, and signs of feminization such as gynecomastia and testicular atrophy in men. Complications such as liver failure, kidney failure, portal hypertension, and bleeding diathesis may also ensue. Liver cirrhosis is a precursor of liver cancer and the most common condition associated with liver cancer. The gross appearance of the normal liver is smooth, fleshy, and shiny compared to the shrunken and distorted mass seen in patients with liver cirrhosis. A number of serum tests are available for detection and evaluation of hepatitis B virus as shown. These tests usually require the expertise of a liver specialist to make a headway in interpretation and diagnosis, as they can be very confusing even to the physician. Additional useful tests consist of imaging like CT scan and MRI, as well as ultrasound. The WHO recommends that individuals with hepatitis B surface antigen should be tested every 6 months and determine whether they will require treatment or not. Ladies and gentlemen, now that we are experts in hepatitis B, let's focus on how the virus leads to liver cancer. Anthony von Leeuwenhoek, a Dutch tradesman and scientist, was the first person to describe single-cell organisms using the microscope he invented in the 18th century. Similarly, Louis Pasteur propounded the germ theory of disease, having had 3 of his 5 children die of typhoid fever. His submissions later opened new vistas in the knowledge of causation of infectious diseases. The product of microbes, which have the capacity to induce cancer, are often the root cause of cancer rather than the organism itself. These microbial products are generally referred to as oncometabolites. A typical example that is relevant to liver cancer is aflatoxin B1, a mycotoxin from the fungus Aspergillus flavus. This mycotoxin is a powerful carcinogen and is usually produced when grains and nuts are not properly stored. In a study in Ibadan on samples of pepper, gari, and other forms of food items in the open market, Bewaji and Bababumi in 2001 found pathogenic concentrations of this aflatoxin. According to the WHO, hepatitis B virus is a class 1 carcinogen. That means it will definitely cause cancer, which situates the virus in the ranks of tobacco in the causation of liver lung cancer. The damage leads to alteration in the DNA and ultimately leads to hepatocellular carcinoma. 80% of cirrhotic livers have a focus or foci of cancer, and cirrhosis is known to be the most common risk factor for hepatocellular carcinoma. Acute hepatitis B virus infection usually resolves unnoticed in most individuals. However, some may progress to chronic carrier state in 5 to 10% of adults and in 90% of children. The trajectory of hepatitis B virus in its full manifestation usually occurs as acute hepatitis, chronic hepatitis, cirrhosis, and finally liver cancer. There are generally two forms of liver cancers, the primary and the secondary. While the primary originates from the liver cells itself, the secondary happens as a result of a spread from another organ. Our study in Ibadan revealed that 92% of liver cancers we see in UCH are hepatocellular carcinoma, Otegbayo et al., 2006. The Cancer Registry, which collects data from 11 local government areas within Ibadan and its environs, in its 2004 to 2008 report on the top 10 cancers in the catchment areas, observed that cancer incidence continues to rise. Among males, liver cancer is in the top 5 cancers in the region. Also, among males, liver cancer has risen to the third most common in recent years. And among females, liver cancer is the 5th most common cancer in the region over the last 10 years. Generally, the major approach to treatment of cancers are surgical resection, chemotherapy, radiotherapy, palliative care, and a combination of 2 or all of the above. Liver cancer at the stage of presentation in our environment is usually in the advanced stage and usually not amenable to therapeutic interventions, making palliative care the only left option. Liver cancer in our setting is a lifetime tragedy, and death after diagnosis is dishearteningly short, occurring just about 6 weeks to 3 months. This is attributed to late diagnosis, as the disease could actually be cured by surgical resection if detected early. In my practice, I have only seen 2 patients surviving up to 1 year after the diagnosis, and both of them academic staff of Nigerian universities. In 2000, I was at the Johann Wolfgang Goethe University Hospital at Frankfurt am Main, Germany, as a postdoctoral fellow, and I saw a number of disease-free patients after several years of treatment. The slide shows a patient at the liver transplantation clinic of the University of Frankfurt Teaching Hospital. The patient actually had a hepatocellular carcinoma. I was looking well-fed and even obese. It was in my amazement that I obtained his permission to have a photograph with him with my analog camera then. The slide showed what I'm used to in Nigeria. The patients look rather wasted and gaunt, with death written all over because of delayed presentation. While the degree of weight loss may be easily attributed to the consuming nature of the cancer, I also thought that nutrition might be acting in concert. We therefore embarked on a prospective cross-sectional study of 276 patients attending the medical, surgical, gynecology, and general outpatient clinic of 2 tertiary health institutions in West Africa. And we found that 45% of patients had 2 meals a day, 34% were at risk of malnutrition, and 5.8% were overtly malnourished. We therefore suggested that nutritional assessment be carried out on patients on admission and adequate nutrition ensured, Otegbayo et al. In 2016. Good nutrition is not known to have a direct correlation with immunity, which helps the body to fight diseases. In 2005, we reported that 80% of the patients with liver cancer rate their quality of life as being poor to very poor, while 60% complained that pain prevented them from performing their daily routines, Otegbayo et al. In 2005. Given the relative number of patients that are unable to undergo curative therapies, palliative care is the preferred option. And this is a specialized care that focuses on quality of life while living with serious illnesses. It is of note that the first hospice and palliative department was established on the 18th of July 2007 at the University College Hospital and currently witnessing some infrastructural upgrading, while serving as a center for training for personnel all over Nigeria and the West Africa disease, and dance to the rhythm, including the wheelchair-bound patients. Mr. Vice Chancellor, sir. My research future is to continue to search in collaboration with like-minded scientists for early warning signs of chronic hepatitis B and effective diagnostic tests in patients with hepatitis B virus infections, biomarkers or tumor markers of liver cancer, which will lead to early detection and treatment of the disease. Biomarkers are assayable biomolecules in the blood, serum, urine, and other blood body fluids that could be used for early diagnosis of a disease entity. Several biomarkers of liver cancer have been studied by experts abroad and by our local research team. Alpha-fetoprotein is the most widely used biomarker of hepatocellular carcinoma in clinical practice. It is not specific and can be elevated in some physiological states such as cirrhosis, viral hepatitis, intrahepatic cholangiocarcinoma, and others. The sensitivity and specificity of alpha-fetoprotein in identifying hepatocellular carcinoma depends on the cutoff value being used, but there appears to be a consensus for 500 nanogram per ml as the most acceptable. In a study by Ola et al. In 2007 at the UCH Valley, they found that 64% of patients diagnosed with hepatocellular carcinoma had elevated alpha-fetoprotein with a cutoff value of 200 nanogram per ml. Other studies also supported this finding. There is increasing evidence that antibodies are produced against mutated proteins in cancers. One of such antibodies that has been studied in hepatocellular carcinoma is the anti-p53 antibody. The p53 protein is produced by the p53 gene and plays a major role in the cell cycle, ultimately precluding carcinogenesis. Mutation of this tumor suppressor gene leads to production of antibodies against this new antigen. These antibodies can be detected in the serum even before the cancer becomes evident. In a case control study conducted by Akere and Otegbayo in 2007, the prevalence of anti-p53 antibody was not significantly different between patients with hepatocellular carcinoma and the normal individuals. Results from a recent meta-analysis concluded that this biomarker has a low sensitivity, further buttressing the fact that it may not be useful for the detection of hepatocellular carcinoma in the early stage. In our studies, Igete et al. In 2008, using plasma DNA, analyzed for p53 codon 249 restriction fragment length polymorphism, they found that this mutation was in 7.6% of hepatocellular carcinoma and none in the apparently normal individual. And this showed that aflatoxin played a key role in carcinogenesis of hepatocellular carcinoma, but the use of this mutation may not attain a sensitive level expected of a tumor marker. Squamous cell carcinoma antigen is a relatively new tumor marker recently discovered to be of diagnostic value in patients with liver cancer. In our study of the comparative diagnostic efficacy of serum squamous cell carcinoma antigen in hepatocellular carcinoma, Choyemi et al. In 2012 concluded that it may also not be particularly useful among Nigerians. Des gamma carboxypyridine is secreted in hepatocellular carcinoma. Ete et al. In 2015 and in 2017 found that sensitivity and specificity of this biomarker is 96.8% or 98.3% respectively. This gives it a higher useful value in diagnosis of hepatocellular carcinoma than alpha-fetoprotein. Also, another tumor marker, glypican-3, is an oncofetal protein that belongs to the family of heparan sulfate proteoglycans and anchored to the cell membrane. Oke et al. In 2019, in another of our studies, reported poor sensitivity and specificity of glypican-3 when compared to alpha-fetoprotein. Also, the cancer testis antigens are a group of tumor-specific antigens and have been found to be highly sensitive and specific for detection of circulating hepatocellular carcinoma cells and tissues. This finding was also corroborated by studies carried out in Ibadan by Ogo and I in 2015. We reported that a combination of cancer testis antigen transcript and alpha-fetoprotein as multi-markers resulted in higher diagnostic yield for hepatocellular carcinoma. Mr. Vice Chancellor, sir, in addition to the aforementioned hepatitis viruses, there are other common microbes in our environment which have the capacity to fatally sting the digestive system and ultimately lead to cancer. To bring the lecture to a close, I would like to touch briefly on Helicobacter pylori, an oncogenic bacterium our research team has worked on. Helicobacter pylori is a bacterium found to be highly prevalent among Nigerians. The organism is the most ubiquitous microbe, which has affected over 50% of the world population, and the WHO has classified it as a type 1 carcinogen in the class of tobacco and of tobacco and hepatitis B virus. It is associated with and considered a high-risk factor for chronic gastritis, peptic ulcer, gastric adenocarcinoma, gastric mucosa-associated lymphoid tissue lymphoma, gastroesophageal reflux disease, and functional dyspepsia. Due to the carcinogenicity of Helicobacter pylori infection, there is a need to invest in procedures that could lead to its early and accurate diagnosis. My team embarked on a series of studies to detect these organisms. The quest to view the internal milieu has been a major force behind various advances and discoveries in clinical medicine. Endoscopy, which is viewing of the inside, has contributed immensely to the diagnosis and therapy of many digestive disorders. Invasive diagnostic procedures for Helicobacter pylori requires esophagogastroduodenoscopy and biopsy, which may be for histology, culture, rapid urine test, or polymerase chain reaction, while non-invasive methods do not require endoscopy. This slide shows me performing a video esophagogastroduodenoscopy to collect samples for Helicobacter pylori. Endoscopic biopsies, recorded images, and therapeutic interventions have obviated the need in many instances for surgery and general anesthesia. In a study by Jemilongo et al. In 2010, using endoscopic biopsies, we diagnosed Helicobacter pylori in 64% of the patients with dyspepsia, the majority of whom had gastritis, which is the known precursor to gastric adenocarcinoma, using the CLO kit for rapid urine test. Together with my collaborators at the Nigerian Institute for Medical Research, NIMA, and other teaching hospitals in a study supported by the International Center for Genetic Engineering and Biotechnology in Germany, we concluded that a combination of stool antigen tests and serology had the highest diagnostic yield in terms of detecting Helicobacter pylori infection. Smith et al. In 2008. Because of the wide exposure to the organism, particularly in developing countries like Nigeria, the serological test is usually positive among patients with dyspepsia and apparently normal individuals. In a research supported by the University of Ibadan Research Grant using serology to detect antibodies against Helicobacter pylori, we found a prevalence of 94% in patients with dyspepsia and 92% in apparently normal controls, Otegbayo et al. In 2004. Similarly, in our collaborative research with the Department of Pharmaceutical Microbiology, University of Ibadan, Adeni et al. In 2012A, we demonstrated a similarly high prevalence of Helicobacter pylori using the urea breath test and tissue culture, though there was a higher detection rate for H. pylori with urea breath test compared to the culture test, Adeni et al. 2012B. This slide shows one of our research patients undergoing urea breath test while blowing into the breath card before being read by the heliprobe machine. The slide shows the heliprobe machine, breath card, and helicap for urea breath test. And this study was supported by the University of Ibadan Mercator Research Grant. The only good story about Helicobacter pylori infection is that it could be treated and eradicated by a combination of antibiotics and proton pump inhibitors. However, one of the drawbacks is the development of resistance to available antibiotics, especially in countries where there is limited restriction of access to obtaining antibiotics. In our study, Harrison et al. In 2017 showed that there was 99% resistance to metronidazole, 33% to amoxicillin, and 14% to clarithromycin. Recently, we in the African Helicobacter pylori and Microbiota Study Group updated the current situation and challenges and concluded that several challenges, including inadequate healthcare system, lack of treatment guidelines and standardized protocols for diagnosis, and lack of data were still issues to be surmounted in the management of Helicobacter pylori infection. Smith et al. 2021. Mr. Vice Chancellor, sir, ladies and gentlemen, I want to end this lecture with a summary of my recommendations to terminate the tragic trajectory of hepatitis B virus to liver cancer. There is a need to identify the factors that encourage the spread of hepatitis B virus infection and thereafter seek means and ways of preventing them. As far back as 2003, we reported that scarification followed by indiscriminate injections was the most common risk factor for the spread of hepatitis B virus among unremunerated blood donors at the University College Hospital. Interestingly, 54% of this subject, there was no identifiable risk factor, Otegbayo et al. In 2003. It is, however, well known that the spread of hepatitis B virus could be vertical or horizontal, while vertical transmission is from mother to child at birth, and horizontal transmission is from person to person other than by birth. In developed countries of the world, vertical transmission is more common, while in developing countries, especially sub-Saharan Africa, the horizontal transmission is more prevalent. This brings vaccines to the fore. Louis Pasteur discovered the use of vaccines to prevent infectious diseases in the year 1885. Further studied by Baruch Blumberg and his colleagues led to the discovery of plasma-derived hepatitis B vaccine in 1969. Several countries, including Nigeria, are signatories to the inclusion of HBV vaccine in the National Program on Immunization. However, the degree of implementation and compliance have been low. In Nigeria, only 41% of newborns are immunized against hepatitis B virus. In our study of healthcare workers at the University College Hospital, vaccinated for hepatitis B virus at the UCH, Ibadan, 59.7% completed the 3 doses of the vaccine over et al. In 2011. This is low, as the healthcare workers are known to be at the greatest risk for hepatitis B virus infection and are supposed to be more knowledgeable. The vaccination rate among non-healthcare workers is then better imagined. I must, however, praise the efforts of the Student Union Government of the University of Ibadan for the concerted efforts and measures it has put in place in the last few years to ensure that newly enrolled students are screened and immunized if negative. They also refer the positive students for follow-up treatment in our clinic. This is a good thing about our students. Mr. Vice Chancellor, sir, in a sad commentary on liver cancer, the European Union Commission declared that the number of liver cancer cases in Africa will double by the year 2050, unless steps are taken now to treat hepatitis B virus. Even if we wish this prediction away, our wishes will be of no effect if we do not perceive the urgency and rise to the challenge posed by hepatitis B to our collective well-being. We in the Liver Cancer Committee of the World Gastroenterology Organization recommended that focus for resource-limited countries like Nigeria should be on prevention and symptomatic treatment, and at best, recession of local ablation where available, for instance, et al. 2009-2010. The International Union Against Cancer, in its World Cancer Declaration of 2014, stated, among others, that this year alone, nearly 8 million people will die of cancer, and left unchecked, the number of deaths will increase to 13.2 million per year by the year 2030. This calls to action to set out goals to be achieved by the year 2025. To attain these lofty goals and terminate the tragic trajectory of the virus to liver cancer, I recommend the following strategies, some of which were published in African Organization for Research and Training in Cancer Plan for the African Continent, 2013 to 2017, Otegbayo et al., 2013. These strategies, A, B, and C, are to prevent viral hepatitis, prevent liver cancer, and promote liver health. Strategies to prevent viral hepatitis. The ministries of health at federal and state levels are to activate and properly fund the special task force on viral hepatitis. The present program for control of HIV should be sustained and made to piggyback the viral hepatitis containment by adopting the successful strategies applied. Mandatory supervised immunization program with hepatitis B vaccine, preschool, pre-employment, and premarital screening for viral hepatitis, among other details. I was introduced to Theatre for Development, TFD, by Dr. Bimbo Benson, one of our young academic staff at the Department of Theatre Arts, University of Ibadan. The innovative way of generating awareness about hepatitis B virus was underscored by the outcome of our study, which showed the enhancement of knowledge, awareness of undergraduate students at the TFD approach, Benson and Otegbayo 2017. Strategies to prevent liver cancer. This involves treatment of individuals with hepatitis B virus-related diseases. Strengthening screening for hepatitis B virus should be non-invasive, readily available, and affordable. Tests for alpha-fetoprotein and a combination of alpha-fetoprotein and ultrasonography. Recent studies have found a combination of other serum markers of hepatocellular carcinoma that yield an increase of predictability of hepatocellular carcinoma compared to alpha-fetoprotein alone. Then strategies to promote liver health. Funding of research on viral hepatitis and vaccine production. Effective collation of vital statistics, which includes birth registration and death, with proper documentation of causes of death by encouraging post-mortem examination. Making healthcare costs affordable by utilization of the National Health Insurance Scheme in all sectors, designation of regional specialized centers of excellence for infectious and liver diseases to provide succor to the afflicted, there is a need for a well-managed hospice and palliative care that will alleviate the pains and sufferings of these patients. Adekolujo et al. 2006 and Otegbayo et al. 2010. My distinguished audience, the sting of hepatitis B is fatal, and the trajectory of hepatitis B in the liver is tragic. All of us must be ready to kill this bee that has no honey in it. On medical education, Mr. Vice Chancellor, sir, I have had a fair share of training of hundreds of undergraduate medical, pharmacy and nursing students at the University of Ibadan and Babcock University, where I was on the University of Otegbayo. I have also trained a significant number of specialists in my field of gastroenterology. Some of them are professors today, and I'm still actively supervising MD, PhD, and fellowships in Ibadan and beyond, even in my present assignment. Some are listed on the table on this slide. Acknowledgements. I solemnly acknowledge my late uncle, Otegbayo Otegbayo, who took me over after my father's untimely death while I was in secondary school. I sincerely appreciate my late parents, Pastor Israel Akobi Otegbayo and Deaconess Florence Otegbayo, for their love and for not sparing the rod at all their efforts strengthened me for challenges of later life. My gratitude goes to my mentors and teachers who guided me through the labyrinths of professional training and academic career. Many of them are seated in the audience. They inspired me and held the torch for me to see. I owe a special appreciation to Professor Ayodele Falashe, former Vice Chancellor, who showed interest in me on the very first day I took appointment as academic staff at the University of Ibadan. I recall how you came to my small office then and offered me some words of advice on how to move up the rungs of the academic ladder, citing your personal experience. I ran with that advice and it worked for me. You also discouraged me from taking appointment as the first substantive head of the Department of Medicine and lecturer at the Ladoke Akintola University in 1998, when Dr. Adele came to recruit me immediately after my fellowship in April 1998, with the assurance that I will be offered appointment at the College of Medicine of the University of Ibadan. And that happened. Thank you very much, sir. Other mentors and encouragers are Professors Oladipo Akikube, Shola Olubide, Adeshola Ogoni, Solomon Kadri, Isaac Adewale, Yetude Akenova, and all the others as listed. They all encouraged, inspired, and guided me. I thank Professor Samuel and Adebo Gakiri, Dr. Bolaji, Oluseyi Akabe, Temitope, and Adede Oshudina of the Gastrointestinal and Liver Unit of the UCH for your support all the way. I wish to thank all the group people that research work made our paths to cross. You have added value to me. Professor Abidi Oluwashola, Professor Stella Smith, Dr. Igete, Professor John Ogumbi, Professor Wolabi, Professor Mujisola Atalabi, Dr. Iduwayede, and many others as listed. I must acknowledge some outstanding organizations and individuals who supported my research efforts through grants and collaborations, which are Fixing Pharmaceuticals Nigeria Limited, Megalife Health Sciences Nigeria Limited, and in fact, Megalife has a booth outside there doing free hepatitis B screening for anybody that wants to do it. And I want to appreciate them. Others are Pastor Thomas Foundation, Pastor Thomas Biomedical Foundation, UI Senate Research Grant, World Gastroenterology Organization, among others. My sincere thanks to all academic and non-academic staff of the Department of Medicine and the College of Medicine. I'm sorry I will not be able to list names because of time. You have been part of my success story and for making me a part of your history. I elect to remember all my patients, dead and living, who volunteered to participate in my research work. To the entire Otegbayo family, home and abroad, thank you and God bless you all. I appreciate my in-laws, the Okulolas, all my childhood friends, Adekunle Adejuibe, Femi Oluwatayo, Kehinde Oluwadiya, Deji Gbadamosi, Ambi Rupewe, Niyi Okulola, and many others who have kept me alive and well. I also want to thank all my people from Otoile, that's my hometown, the Obala, and Comrade Saliu Bello. I appreciate you. Currently, I'm the president of the Society for Gastroenterology and Hepatology in Nigeria, and my vice president is here, seated there. Thank you very much, Dr. Olukoba. I want to thank our friends from Bowen University who have come to support my wife and indirectly supporting me too. Like-minded groups, my brethren at Vine Branch Charismatic Church, UCH family, you are too numerous to mention. I can see many of our nurses who have been seated here since about 2 p.m. just to be part of this. I appreciate you. I was a member of the Man Work Club of the University of Ibadan for 5 years out of the 6 years I was on this campus. So they honored me this afternoon as I was coming in. Other friends too numerous to mention and many well-wishers. You are all been wonderful. Now, how do I appreciate my friend, my sister, confidence, mother figure, and one of my youth for standing by me at all times. My black rose, you are indeed the fulfillment of the scripture in Psalm 128 verse 3 in my life, which says, your wife will be like a fruitful vine in the very heart of your house. Your children like olive plants all around your table. In fact, I dedicate this lecture to her because I had already given up on doing the lecture. But she encouraged me and said I must do it. And all along, she bought the suit I'm wearing, dictated the shirt, bought the shirt, everything. We thank our loving children, David Oluwatushi and Sharon Oluwadelade, for carrying on the family name with dignity. Finally, to my Creator and Savior, the Lord Jesus, who has given me the grace for this modest attainment. To him all alone is glory and honor. Indeed, he is the one who raises the poor from the dust and lifts the beggar from the ash heap, to set them among the princes and make them inherit the throne of glory. That's 1 Samuel chapter 2, verse 8, and Psalm 113, verse 7. He has made all things beautiful for me in his time. For being a wonderful audience, I extend my gratitude to you all and for your silent eloquence. Mr. Vice Chancellor, ladies and gentlemen, men of the press, this is my story. I thank you all.